I'd like to call the next speaker now, Dr. Tadanki Ramakrishna.
Yeah.
Dr. Tadanki will be speaking on how to do Phaco in hard cataracts, the fundamentals.
Good morning. Now I'm going to talk about top pearls in the management of hard cataract. Hard cataracts are difficult even for the most accomplished surgeons because the lens becomes thick, bulky, it gets compacted, it stretches the capsule, and the capsule gets thinned out over a period of time. And because of the thickness of the cataract, the anterior chamber also becomes compromised. Because of the weight of the cataract, the zonions also become weak. So you have a very difficult case to handle on the particular day. So what is very difficult for one person may not be that hard for an experienced surgeon. So before we take up a case for surgery, one should do a thorough slit lamp examination of the patients. So we should look for corneal opacities, corneal dystrophies, endothelial disorders, and one should take a note about the anterior chamber depth, a presence of pseudoexfoliation or a pigment dispersion which might indicate a previous inflammation. One should also take a note about the size of the pupil because a smaller pupil adds to the difficulty of the surgery, and one should also take a note about the presence of any posterior polar cataract. So while examining the retina also, one should also look for old vascular obstructions, a glaucoma, a old RD or any other factor which might indicate a poor vision in the post-operative period, and one should always caution the patient about that. And one should also take a drug history also for a possible IFIS because presence of IFIS will complicate the surgery even more. So one should inquire whether the patient is on tamsulosin, benzodiazepines or antipsychotic drugs. And one should also counsel the patient about a prolonged intraoperative period, a prolonged recovery time, and a possible extended use of medication in the post-operative period. So unilateral cataract in one eye with little or no cataract in the other eye should always alert the surgeon about a possible old trauma or inflammation. So preoperative examination, if the visibility is poor, then one should always do an ultrasound B scan to rule out any vitreous hemorrhage or any choroidal masses or any advanced cupping. So all these things one should look for. And one should never give a positive counseling to the patient if the retina is not visualized. So then coming to the biometry, if it is possible, one should always do an optical biometry. But this is also quite difficult because point number one is that the patient cannot fix it on the target, and number two, light cannot traverse through the dense cataract. SSOCT based biometers like Master 700 can give a good biometry even in a very dense cataract, but if you cannot do these, one should always route back to ultrasound A scan. The choice of the surgery depends upon the experience of the surgeon, and if the surgeon is experienced enough, Phaco is the choice, but for a less experienced surgeon, it's always better to do SSCS or Phaco with a scleral tunnel because one can always convert to SSCS in case the surgery is not going or proceeding the way you wanted it to go. So I'm going to enumerate the top 10 pearls in managing a hard cataract, which I'm going to elaborate in the coming slides. So the first pearl is to make an anterior entry while you're making the tunnel. So because the density of the cataract, because the anterior chamber is compromised, these patients have a tendency for the iris to prolapse. So if you try to reposit the iris with some blunt instrument or something repeatedly, the pupil might become smaller. It adds to the difficulty during the surgery. So one should always make an anterior entry. So this risk of iris prolapse becomes more when you're doing the phacoemulsification because of the egress of the fluid through the ports. So after making the ports, then one has to stain the anterior capsule, and one should always stain the anterior capsule because the red reflex is not really good. So this gives a better visualization, gives a better color contrast, and making the rexis becomes easier. So this avoids injury to the anterior capsule while doing the chopping, while removing the nuclear fragments, and it also helps in accurate placement of the instrument while doing a horizontal chop. But my suggestion is because in these patients you don't have much of a cortex and there's absolutely no place between the capsule and the nucleus, it's better we avoid a horizontal chop. I say horizontal chop is contraindicated. So without stain, even a successful rexis is difficult to see. So once we stain the anterior capsule, then we reform the anterior chamber with viscoelastic. So because you have a very dense cataract, you have a long operating time, you will be using more amount of energy to emulsify the nucleus. So one should always use heaps of viscoelastic. So I do my variation of software technique in which I inject a cohesive dispersive viscoelastic first, and beneath that I inject HPMC, which pushes the cohesive dispersive up towards the endothelium and protects that. So plain cohesive like sodium hyaluronate doesn't really help because it gets easily washed away. So while doing the surgery also, one should always interrupt the surgery in between to replenish the anterior chamber with OVD whenever required. So after the anterior chamber is reformed with the OVD, then one has to make a rexis. The sizing of the rexis is very important, and one should always aim for 5.5 to 6 millimeter rexis. So if you have a small rexis, then chopping of the nucleus or removal of the nuclear fragments is difficult, and one might accidentally injure the anterior capsule also. And if you make a large rexis, probably you will have difficulty getting a adequate overlap on the optic. So it's always better to use an retractor forceps to have a better control while doing the rexis. So after the rexis has been done, one should ensure a mobile nucleus. So one should always keep in mind, as I was telling you previously, there is no cortex here, very little cortex here. There is always a chance of a capsular lenticular block. So you try to do a aggressive hydrodissection, then probably you might break the posterior capsule and nucleus might drop into the vitreous. So what happens in capsular lenticular block? Because there is no cortex, if you do a aggressive hydrodissection, the fluid will push the nucleus up and seals the rexis margin. So the further amount of fluid which you inject is going to break the capsule and finds its way into the vitreous. So after you do, how you do the hydrodissection? So you have to inject a small quantity of fluid in multiple quadrants and frequently tapping the nucleus below by burping out the excess amount of fluid in the posterior chamber. So after we do the hydrodissection, then one should always rotate and make sure that the nucleus is mobile in the capsular bag, whether it's completely broken off all the adhesions. So a non-rotating nucleus can be difficult. It can cause stress on the zones. One might end up with a zonal dialysis also. So before we start the phaco emulsification, one should always expose the phaco tip more than usual. And there's a time we start doing the phaco emulsification. This is the most important pearl I want to make. So the depth of the trench is more important than the length of the trench. In some videos, I see some surgeons making a huge trench from equator to equator, and this is absolutely not essential. You just need to make about 3 to 3.5 millimeter trench at the center. So you're doing two things there. The one thing is you are weakening the posterior plate, and you're getting a good amount of the meat of the nucleus to get an adequate purchase while doing the chopping of the nucleus. So whether to do a horizontal chop or the vertical chop is purely a surgeon's choice, but it's always better to avoid a horizontal chop. So once we make two heminuclei, then it's time to subdivide the nucleus into multiple quadrants. It's like eating a slice of cake instead of eating a whole cake as a whole. While doing the while subdividing the nucleus, one should remember that these nuclei are thick and leathery, and it doesn't crack very easily. Don't get an adequate separation. This is because the epinucleus gets compacted with the endonucleus. This epinucleus runs on the posterior surface like strands, gets thickened and hardened over a period of time, and this is what gives the leathery nature for this cataract. So even after you make it into multiple fragments, what will happen is that these fragments are attached to the center like a flower petal. So it's very difficult to get an adequate separation. So what I do is I have my own technique, which I call it as a push-up and stip technique, where I push the fragments towards the periphery. So the central part comes up, it's away from the posterior capsule, then I hit it away with the phaco handpiece. So then I can always emulsify the nuclear fragment. So whatever technique you use, whether it's a divide and conquer or you do a stop and chop, the resultant fragment is always larger than the lesser grade cataracts. So if you have a larger fragment, the fragment gets deflected away from the phaco handpiece. So it's always better to have a smaller fragment. So take some time and make it into more number of fragments instead of struggling with a bigger fragment. So one should always create a visco wall. So visco creates an artificial epinucleus, gives some space for you, it pushes the posterior capsule down, it coats the endothelium and protects it. So as long as you have the nucleus in the capsular bag, it holds the capsular bag in place. So while removing the nuclear fragments, what will happen is the posterior capsule comes towards the phaco tip whenever you have a post-occlusion surge, and it is a great risk of injury with the phaco handpiece. So one should always use huge amounts of viscoelastic. So this is the power modulation. This is one more very, very important point I would like to make. So power modulation is very important. So one has to use a high vacuum and a moderate power. So the usage of high vacuum decreases the need for higher amount of phaco power. So if some time is there, maybe I would like to elaborate. Recently I was doing a bit of a study, like I was checking, my machine has got a dual linear control also. So dual linear, I go up to 330 millimeters. When I went up to 330, even in a grade 5 cataract, I could emulsify the nucleus is 25 to 30% of the phaco power. But when I am just going in the linear mode at 200 millimeters mercury, I could emulsify at 55 to 60% power. So it's always better to use a high vacuum while emulsifying the nuclear fragments. So one should always emulsify in the iris plane or below that, but never above the iris plane in the anterior chamber, because you might fry up the corneal endothelium. So one should always use a huge amount of viscoelastic. So when to stop the surgery? Whenever you see a smoke kind of thing near the phaco tip, the lens plume, which we call, it indicates a blocked tip. It's because of the big nuclear fragment going and blocking the phaco tip. This will raise the temperature in the handpiece and might cause a wound burn. Even a high viscosity OVD can cause clogging of the phaco tip and can cause a wound burn. So wound burns should always suture, because there's a high risk of astigmatism. So one should always be prepared to convert to SICS whenever you feel that the surgery is not going the way you want it to go. So one can do either a scleral tunnel in the same plane, in the same area at a deeper plane, or one can change from temporal to superior or vice versa. So what are all the dangerous signs here? So if you feel that the phaco is inefficient, it might be because of the vitreous in the antechamber, you see the nucleus tilting, or the PC starts suddenly looking very, very clear. All these things indicate the PC rupture. So points to remember, before we start off the surgery, are incisional burns, the capsular integral block, a potential endothelial loss due to high energy and a particular turbulence, PCR and weak zonules. So the two most important pearls which I want to again repeat here, number one is the depth of the trench is more important than the length of the trench, and a power modulation. Use a high vacuum and a moderate amount of power instead of using a high amount of power and frying the cornea. Thank you very much.
Thank you, Dr. Ramakrishnan. That was a wonderful presentation.
Thank you, sir.
Each and every point you have covered.
Thank you.
That was wonderful. I don't know if there are any beginners over here. They're all experts sitting over here. But if there are any beginners, I think you should take a copy of his presentation to see all the points that he has already covered. Anybody has to say anything?
A very excellent presentation for especially for the beginners.
Thank you.
But I think the depth of the tunnel, the width of the tunnel is also important in the hard cataract, because otherwise it leads to the blockage of the sleeve. So the width should be also, width of the tunnel is also important. Number second, the learning of the chopping manuals in hard cataract is very important, because in soft cataracts you need not to chop the things, but in hard cataract it's very important to chop properly.
Yeah.
See, for the beginners, not for the experts, the black cataract, white cornea is the joke. If you operate a black cataract, you will land in a white cornea. So to avoid that, your power should be away from the cornea, in which good old method of 4 quadrant. Make a quadrant, trench, horizontal trench. You got 4 pieces. Your aim is 8 pieces. Make each quadrant into 2 pieces. You get 8 pieces, all are within the bag. Afterwards, you use high-end visco, even from the beginning, and you do quadrant by quadrant, you get excellent results. This is for the beginners. Experts, whatever you are comfortable, you do it. Do 4 quadrant, make into 8 quadrants, 1 quadrant by 1 quadrant, take your own time. Your own time will causes cooling of the endothelium, cooling of your wound. But attempt these hard cataracts with high-end missions only. With the low-end missions, attempt SICS.
That's true. That's true.
Okay,
go ahead. So the earlier dictum was that you go on making the trench so much so that you just about begin to see the red glow, which is now not so much true. Now we go halfway, and then with high vacuum machines that we have, we make a chop and we crack the nucleus. So high vacuum and a hold is very important.
The thing is, no, you really don't have to see the red reflex, so you don't have to go so deep.
Yes.
So if you can trench the nucleus at least 60 to 70%, I think you can comfortably crack the cataract.
Correct.
I was telling you, like I was seeing one video where the surgeon was trenching almost 50 to 60 times. It's unnecessarily, you're releasing so much amount of energy inside the eye. And probably you don't know, you're literally frying the endothelium there. No, it's really not really essential. So just make a small trench, that will really give a good, nice crack.
Yeah. Nice. So one more thing I feel is that the last piece.
Yeah.
That is a problem for the beginners, and even most of the surgeons have.
So the last piece, two things are there. So one thing is the post-occlusion search, And this thing has got the sharp edges, so probably if it tumbles, it might go and break the posterior capsule. So frankly, it never happened to me, but theoretically it can always happen.
But there are some points there. We can put an IOL scaffold technique for the beginners.
Yeah.
So the IOL can be put before removing the last piece.
Yeah.
So one is that, and or you can put a visco down,
Visco is
down the piece.
For last piece, use visco.
No,
number third is that you can put some instrument like iris repository or anything below the phaco tip, so that the PC does not come up.
so my suggestion is take a minute or more, inject more amount of viscoelastic, than to have a very unsatisfied, dissatisfied patient for weeks or months together in the post-operative period. So I think using loads of visco, I think, is the key for a successful surgery in a hard cataract.
Especially once you are doing a phaco, in between also you have to use the visco. That's more important to coat it.
Thank you very much. We'll move on to the next topic by Dr. Tripura Velagupadi, and she'll be speaking on phacoemulsification.
Excuse me, so there is one question from...
Please,
please, Shigin.
Sir, in my college I have got a very basic machine, APA only. So, and I do hard cataracts with them. So we apply burst mode. So most of the barring few occasions, cornea is okay.
Probably you are expert.
No, I'm saying give some suggestion. You said only with a high-end machine. We don't have high-end machine. It means I won't be able to do hard cataract. But I do it with the burst.
If it is a black cataract, I suggest
black cataract I don't. Brown cataracts I do regularly. With the burst mode, it works
What
well.
about your results?
It works well.
Huh?
It works well.
It
Barring
will
few
Works well.
cases.
Have you studied the endothelium?
No, sir, I don't have the mode to study that.
Yeah,
Cornea
please
is
study the
clear.
endothelium, at least 20 cases of your brown cataract.
Cornea is clear. I don't
No,
have
no,
anything else.
not the you have to follow them for 15 years.
Okay.
You are not totally wrong. Burst mode is a lesser phaco energy and much safer to do. So burst mode is a good idea.
Repeated use of viscoelastics, what he
With
said, that I
repeated,
do.
yes.
So that
I
High
think
molecular.
the burst mode or pulse mode can be used for a direct job.
Direct chops and for emulsifying the pieces also.
I
you
mean
can
that
use burst
once
mode
you
so that
use the
phaco
burst
power
or
is
pulse
less.
mode, that will, with a direct job, that will decrease the energy level.
Yes.
Mm.